All right, I think we'll go ahead and get started. Welcome to another edition of Virtual Global Spine. I'm especially excited about this week because we have four of my colleagues here. I have no idea how we managed to get them all on the same date, but this is a little bit of a miracle here tonight. So you'll see two of my neurosurgery colleagues and two of my orthopedic spine surgery colleagues, all of them stars in kind of different areas. You're going to see they all bring something a little different to the table. And all of them do obviously very different things than I do as a tumor and open surgeon. And so I'm always especially excited to see their cases because I was just talking to Closie today and was asking him questions about a case because I always learn something from him. So I'm going to get out of the way. I'm at the airport, and so I might try to fade into the background here at some point, and I might lose the internet at some point. But I'm going to turn it over to these guys and let them get going here. And guys, thanks again for doing this. Is excellent.
Thank you. Happy to be here. I'll go ahead and get things started. Thanks for the introduction, Matt. My name is John Ogalade, and as Matt said, Dr. Goodwin said, we all have the pleasure of presenting on modern management of degenerative spondylolisthesis. And I'll actually be talking specifically about the endoscopic approach to degenerative spondylolisthesis. Here are my disclosures and a shameless plug. If you're interested in learning more about endoscopic spine surgery or getting more endoscopic spine surgery content, you can follow me on social media. And if you're interested in joining an international community of endoscopic spine surgeons, I would ask you to just visit our website at isurf.org for more information. With that, the key benefits of endoscopic spine surgery, have been outlined in numerous publications. And I think this is just a quick slide kind of showing, the different reasons why you may consider doing endoscopic spine surgery and adding it to your armamentarium. However, the research shows that, it's pretty effective. And the way we do research, high quality research, is with the Endoscopic Spine Research Group, where we use a smartphone app to collect patient reported outcome measures. And through that app, through the use of that app, we're able to actually perform high quality research and look at data and provide meaningful, guidance on the use of endoscopic spine surgery, where it works and where it doesn't work. And you can see these are several papers that we've just published over the last couple of years since the inception of the group. However, today I kind of wanted to want to focus on this particular paper, looking at lumbar endoscopic unilateral laminectomy for bilateral decompression in degenerative spondylolisthesis. And this paper was, a group of 73 patients from multiple institutions across the country. And we specifically looked at patients who had neurogenic claudication due to severe stenosis in the setting of degenerative spondylolisthesis. And what we saw was that all these patients, of course, were treated with lumbar endoscopic unilateral laminectomy for decompression. And of course, retrospectively reviewing the data, we found some very interesting findings. And so here's an example of a case. This is a 68-year-old male who presented with, neurogenic claudication and had evidence of a grade 1 spondylolisthesis at L4, L5. And you can see on this MRI, there's actually a synovial cyst there. And this patient really wasn't interested in pursuing a fusion up front, but I did think that, he was a candidate for endoscopic laminectomy, essentially a ULBD approach to decompress his neuro elements. And the goal, of course, is to prevent him from having any worsening of his spondylolisthesis. So we get flexion extension x-rays for all of our patients who present before undergoing endoscopic spine surgery. You can see this is a dynamic slip. There's no evidence of dynamic instability. So postoperatively, the patient got flexion extension x-rays as well. You can see that it did not get any worse. And you can actually see this is this laminectomy defect that we created during our endoscopic approach. Surprisingly, when we started these cases at WashU, it was hard for anyone to even know that we did surgery. So we had to start telling them, hey, there was a laminectomy defect there now. So it's quite interesting to see how these patients do, which is how we, use our data. We collect our data to do research, and you can see this patient did really well after surgery. He's 2 years out from surgery. And the way I would kind of follow your eyes is this is his preoperative assessment here. And then immediately after surgery, his disability got a little bit worse, but didn't need a lot of pain medications. You can see that his back pain trended downward within the first week of surgery. His left leg pain got better slower than his right leg pain. And overall, he's walking much more than he was before surgery. And then, of course, comparing his pre-op and his post-operative flexion extension x-rays, maybe it's my eye that I'm really hoping that this guy's got more motion in his general just range of motion between flexion and extension. But what we do know for certain is that his slip did not get any worse. And this is at 1 year post-op. So our goal really is to take patients who have, degenerative spondylolisthesis and severe central canal stenosis, and then treat them using an endoscopic approach so that we can decompress their neural elements and make sure there's no further neural element compression, and then also avoid any worsening of that slip. So how do we get there? So this is kind of like a little, workflow for how we do endoscopic surgery, but of course you would need a more detailed practice for the ULB approach. But this is kind of just a summary. So you want to start with, of course, in the OR, and after you've selected the appropriate patient, tilting once the patient position on the Wilson frame, I would tilt the C-arm caudally so that I can maximize the interlaminar window, superimposing the spinous processes and the interlaminar window over the disc space. Once we've made that approach with the C-arm, we now know our trajectory to get into the spine, and our goal is to hit that target area, which is the inferior edge of the rostral lamina, with our dilator tube, and then eventually our working tubular, working channel, or working tube, I should say, or tubular retractor. That's a better term to use. And so you can see here, that's where it would sit, and then we would be able to work and decompress the ipsilateral side, and then go contralateral to the opposite side. And so this is a real case example. You can see that we've now identified our inferior medial edge on the skin, and we've identified the approach angle for the C-arm. We're now going to hit that target area and then place our working tube. And once our dilators docked on the inferior medial edge of the lamina, and then we use our working tube or tubular retractor to dock there, and then we can use that to go contralateral. And when you bring the scope in, the first thing you're going to see is muscle. And I kind of want to go back to saying that this is a muscle sparing technique because the amount of muscle trauma is minimal. I use this thing I call the underwater bovie. I'm sure that there's going to be better iterations and things to use from the various endoscopic companies in the space. However, the goal really is to expose that lamina surface that you were targeting. So to orient you all, we're on the patient's left side. So that means that the left side of your screen is cranial or rostral, and the right side of your screen is caudal. And you can see lateral would be at the bottom of the screen, and 12 o'clock is medial. And what you're seeing here is that there really isn't a lot of muscle cutting or destruction. We're really just using this underwater bovie to kind of really expose that inferior medial edge of the lamina. And of course, once we have that inferior medial edge of the lamina exposed, we can actually use our high-speed drill to undercut the ligamentum flavum from its ventral attachment to the lamina. So we've done some drilling here now, and now you can see this arrow is kind of pointing at the attachment of the ligamentum flavum to the ventral surface of the lamina. And this is actually where you want to focus your drilling. So I like to use a high-speed diamond burr, but there's of course many different shavers and different attachments or burrs that you can use. But I find that this works great in my hands, and I'm really happy with the hemostasis that it allows. As you can see, there's not a lot of bleeding in this case. So what I'm doing here is I'm using this high-speed burr to kind of push down on the ligamentum flavum and really focus my drilling on that ventral surface attachment. And I like to work all the way cranial until the attachment of that flavum comes off. And you can see in this slow motion kind of instant replay that we're really focusing the drilling on where that attachment of that ligamentum flavum meets the ventral surface of the lamina. And we're right about at the attachment or the insertion of that ventral rostral ligamentum flavum. And you can see now that that flavum is pretty much detached rostrally. And then what we would do is do the same thing all the way out laterally. And then of course, at the inferior border or at the caudal attachment of that same level lamina. Just kind of pointing out here where that ligamentum flavum is completely detached. And then how we eventually would just use a kerosene to remove the rest of that ligamentum flavum. The cool thing is with the endoscope, with the water irrigation pressure, the irrigation will help push the dura and the neural elements away from you. So now that we've done our decompression, we've removed the ligamentum flavum, at the end of the case, this is what you want to see. You want to see that you've completely decompressed the bilateral lateral recesses. So you can see, again, we're on the left side, cranial to the left, caudal to the right. In front of you there is the contralateral lateral recess. And then you'll see that this instrument and that traversing nerve root on that side is completely free. Then you can see on this side here on the ipsilateral side that the traversing nerve root is completely free and decompressed. So what you can see in this image here, we have a preoperative and postoperative comparison MRI showing decompression, a significant improvement in the degree of stenosis and the successful decompression at that level. And our study conclusions showed that, one, we didn't have any complications or mortality within our cohort. There was a significant improvement in the leg pain and back pain for our patients. And overall, there was no progression of the spondylolisthesis that was observed at 1 year postoperatively for all the patients within the study. So again, the benefits of endoscopic spine surgery when applied for the ULBD approach is that it's a non-limiting surgical procedure, which allows for motion preservation. We also are able to, eliminate this surgery does not eliminate any other, surgical approaches. So if the patient ends up needing more surgery or needs to have a revision surgery, you can still do more surgery as there's not been a lot of destruction to the normal anatomy. In some cases, we do perform these surgeries under a regional block. And this picture here just illustrates the difference between someone who had a MIS decompression and this incision for a revision endoscopic decompression. I'll take a quick second to highlight our endoscopic spine surgery program. We're constantly improving and hoping to help the community within the St. Louis region in our catchment area. And currently we have 6 surgeons who offer this technique within their armamentarium, and we're doing close to or more than 350 cases a year. And we're right now operating out of 3 hospitals, and that number is growing. So if you're interested in doing a dedicated fellowship for endoscopic spine surgery, I encourage you to reach out to our fellowship coordinator at our WashU neurosurgery website. And of course, these are my references, and I will yield the rest of my time to Dr. Hafez. Thank you.
So quick question, probably for all of you, but I'll start with you, John. So when you do these cases, I asked this because I asked Chloe this earlier today. I had a patient come in who had a very MIS procedure. I don't know if it was endoscopic or tubular, but it was a very tight corridor. They went down to do a decompression. They had a little fluid collection that needed to be decompressed. But what I learned from it is when I opened it, which I just did open because they had caught equina, I was surprised by how good the soft tissue looked. And in the surgery, the prior surgeon had taken away a lot of the facet. And when I looked at the CT, I thought, boy, that looks terrible. That's going to be unstable. When I opened it, the tissue looked so good around that area that it had me rethinking kind of what would be unstable in these cases. And so can either any of you guys really speak to kind of how much difference does it make when you do these kind of smaller approaches and the tissue's all intact around the facet?
Yeah, I'll take a first stab at it. And I'll say, when it comes to doing these surgeries, MIS or whether endoscopic or tubular, for the most part, because you're using tubular dilators, you're not really cutting and destabilizing the blood supply to the muscle. So there's a good potential for minimal scar tissue and healing of that muscle. And you're not necessarily denervating them either. So that muscle supply helps stabilize the spine. In general, I always try to send patients to physical therapy to help them improve their core strength before surgery. And I'm finding that doing that preemptively makes the recovery even quicker. But I think when we look at biomechanics, for those who have a stable and a non-dynamic slip, the chances of it getting worse, even with the tubular decompression, is pretty low, especially if they have good core strength.
Yeah, the other thing I would add to that is I always describe endoscopic as an outside-in surgery, or sorry, inside-out surgery. So you're doing your work from the inside, as Dr. O showed, you're drilling out the ligament, but you don't do much destruction of the external structure. So the external facet capsule should still be intact. The muscles and some of those interspinous ligaments are still undisrupted and intact. So even if you over drill and drill out some of that facet joint on the inside of it, the outer facet capsule and structures are still relatively preserved, which actually adds to that stability aspect. So as Dr. Ogunlade did, he kind of showed the least invasive approach to treat this, and with good results of not inducing stability issues. I'm going to kind of switch gears and go to something that's a little more invasive as far as stabilization and fusion. So this is more looking at a modern management in the setting of a navigated prone lateral. There we go. No real conflicts here, but this is going to be mostly Globus products, just so you're aware, I do work with Globus. So this is a case, this is a 50-year-old female who has both back and leg pain. You can see on her sagittal MRI, she's got a grade 1, almost grade 2 spondylolisthesis with about 8 to 10 millimeters of a slip. That leads to a lot of severe left lateral recess stenosis and facet arthropathy, probably some exiting foraminal stenosis at that level as well. On her flexion extension, you can see from flexion to extension that spondylolisthesis fully reduces, which is really contributing to her back pain. Because she has both back and leg pain, that kind of limits some of the treatment options we can do. Sometimes if it's just one or the other, even if it's mobile, especially if it's more leg pain, we might do an endoscopic decompression. As we just mentioned, it's less destabilizing, but it still is destabilizing to some extent. So if there's motion there, that may not be the best option. So I always break every surgery down into my conservative and surgical options. So in this setting, it'd be steroid injection, epidural, or transforaminal if it was just that left L4 nerve that was really being bothered. If it was more back pain related, then more just facet injection or ablation. And then if this was going to be fusion, would this be just a fusion or a decompression? Would I do something endoscopic here, or given that there's about 10 millimeters of mobility there, is this going to end up being a fusion? Would I do this open or percutaneous? The majority of my practice is MIS percutaneous fusion. So for me, this is always going to be a MIS perc case. And then again, if it's going to be open, you can do a posterior lateral fusion, or you're going to do some form of interbody facet fixation fusion in the setting of a perc case. And then how would you treat that? 4 or 5, I usually don't do A-lifts first. I'll do something as a lateral or a T-lift, and generally a lateral, which you'll understand at the end of this case. So every one of these are good options. Not one is necessarily better than the other. They're all tools in our armament we must all know and use in the right scenario. But in this case, why I think lateral overall is the best interbody approach, especially outside of an A-lift. Generally, it's a pretty small incision. There's pretty minimal muscle disruption. You have a natural corridor from the external, internal obliques and transverse all the way down to the spine itself, versus traversing through the posterior musculature. You generally avoid most of the neural structures if you do this properly. You really shouldn't intervene with any nerve and cause any nerve damage. And then you really get a good large graft footprint. So in this top right photo here, this is a picture of a large T-lift. This one, it articulates and expands versus a 50 millimeter wide lateral interbody. So you can just see the size, height, width, everything about a lateral graft is much larger, which leads to its ability to have significant coronal and sagittal realignment capabilities, especially in the setting of anterior column reconstruction, versus doing something that's a little bit more morbid and higher blood loss, such as PCO or VCR. The cons to laterals, it can be disorientating. It's an unnatural view for some people, so it takes some time to get comfortable. It's very anatomically dependent, so depending on the patient's muscle, vessels, nerves, crest, all those things can be tricky. And spondylolisthesis, which I'll touch on here. And then sometimes you may not be able to get into the retroperitoneum if they've had previous surgery or scarring. Why I think prone lateral is the best option over a lateral decubitus option is it minimizes the need for any repositioning. You get more improved lordosis in the setting of someone being in a prone position versus on their side. It's a more natural workflow for someone, especially for us as surgeons. We're very comfortable in the prone position here. And it's also more amenable to navigation. So you can see here the reference frame is in the PSIS out of the way. We have working chairs, Dr. Closey here, working through the lateral corridor here. But everything really is amenable for nav. And then really the best benefit is you have access to the anterior and posterior column simultaneously. So you can do osteotomies posteriorly, release facets, reduce a spondylolisthesis, and then do your interbody work all at the same time, versus when you're in a lateral decubitus position, you're somewhat more limited into the options you have, especially if you're going to do anything from a posterior standpoint. So there are some pros to a direct lateral, a lateral decube position. You have access to the entire spine, so you can do laterals from L1 to L5 and a lateral A-lift at 5.1. So you do have more access in that regard. It's a little bit better visualization from the way that gravity can impair your view with retroperitoneal fat in a prone position. And then also it's a shorter working distance. When you're in the lateral decube position, that adipose tissue falls away from you and it decreases the distance from the skin to the spine. But in a prone position, when you're on a prone positioner, that would actually push that fat more laterally and lengthens that retractor by about 20 to 30 millimeters overall. But pros of the prone, I kind of touched on most of these. You have complete access to the posterior column. You can do long segment fusions. I'll routinely do a T10 of the pelvis with lateral, sometimes T4 of the pelvis with a lateral, but without any need for repositioning. And you get better lordosis on a lordotic table. This is an example of one of Globus's positioners, but all the ones on the market have similar properties. You have a chest pad of some form that with attachments that will lock the chest in, and then a hip pad that will also lock in around the greater trochanter, and then both will rotate. So the chest pad will rotate away, the hips will rotate to the feet, and that really takes that crest and that bottom rib out of its way. So you have a larger working corridor, so you have a little bit more access, especially if you're going to work at 4-5 or 2-3. It takes those bony structures out of your way. So in this case, she has a mobile spondylolisthesis. So for her, we definitely did a prone lateral here. So to start off, I'm marking out my PSIS for navigation, but I always mark my landmarks in case navigation's off. I can still do this with X-ray fluoro. And then as we mentioned, this chest pad is going to rotate to the head. The hips are going to rotate to the feet, and that increases that working corridor there laterally. For me, I'm a navigation person because I do everything percutaneous. So the first step of the surgery is really pre-planning my screws. So I'll plan out where I'm going to place my screws, where I'm going to place my inner bodies, and then using navigation, whether it's freehand navigation or some form of robotic navigation, that really helps limit my incision size and my muscle damage to decrease the disruption of the tissue and the postoperative pain. And then step one really then becomes the navigated screws here. This is the Globus robot placing the screws. You can see for this 4-5 fusion, this incision is just about a little bit larger than an inch. These are the reduction tabs on the rods that will come in handy here in a second. And this is the lateral for this patient. She still has a spondylolisthesis, but you can see it's a little bit more reduced when she's in a prone position than it was when she was supine or standing. Step two is doing the inner body portion from the lateral. So I'll use the navigation to mark out the disc line from the anterior to posterior portion of the vertebral body, and then just blunt dissect down till I get to the psoas and TP. And then this is really the best part of any navigation is having a navigated dilator. This will save you many steps of trying to find the disc space and it'll save you a lot of radiation exposure to yourself and to the patient. Just having the ability to navigate that dilator in, and then you can take off that back portion and then serial dilate and put your retractor over it. So this is what it kind of looks like in the OR. Here, I'm using the fixed arm of the robot to stabilize the retractor. You can see here it's the 150 blade length. So anyone who does lateral surgery, usually it's 100, 110, maybe 120 on a long. Most patients, at least here in Missouri, are going to be in the 140 to 160 range. But with this, you have a good corridor. That's actually the disc that came out in one piece there. And then this is what the intra-op x-rays look like. And one thing that might stand out to you surgeons is looking at the x-ray with the rods in place. So this is, again, an advantage of prone position is I was actually able to put a rod in and reduce the spondylolisthesis and then put my graft in. That way I get perfect apposement of the apophyseal ring. So I can put this expandable implant right at the strongest portion of the bone. And then once I have this touching end plate, I just release my top set screws, loosen that rod, and then I can expand this up without worrying about putting this in with a unopposed apophyseal rings in the setting of a grade 1 spondylolisthesis. So for 1 year later for this patient, she did really well. You have great bone fusion across and through that graft there. Her x-rays have been good. She's actually 3 years out now, still doing really well. Her pre-op MRI, you can see here, she's got the slip and narrowing there. That's her 1 year post-op. You can see we restored alignment, height, and lordosis. And then one of the other big powers about this, expandable technology or indirect decompression. This was her pre-op MRI. And this was not any direct decompression. This is just indirect decompression. Same level. You can see that that disc is completely gone. That ligament thickening is gone. The facet's actually a little bit smaller. So just with indirect decompression alone, we were able to decompress lateral recess, exiting nerve, just with the power of distraction across that disc space. So in my opinion, prone lateral is one of the most powerful techniques for treating a spondylolisthesis. Allows access to the anterior and posterior column, so you can reduce it before you do your inner body work. You have a very large surface area, so higher fusion rate, lower subsidence rate. And then again, just as we show, you get really great indirect decompression, especially with expandable technology, but even with a large static inner body, you can really stretch that ligament and that disc space out, and over time that will repair. That's about it. Turn that back to the group.
So we've seen endoscopic, we've seen prolateral. Maybe you both can make a comment about how much of that was part of your training versus learning it on your own, going to different things, and how that process worked.
So in my residency training, we did not do any prone laterals. We only did lateral surgery. And then no endoscopic in my residency program training, but I did a fellowship at the University of Washington in Seattle with Christoph Hofstetter, and that's why I picked up the endoscopic technique. And it's been one of the main things that I do for most patients when they see me in clinic. I always look for an endoscopic approach before offering a fusion.
Yeah, I did lateral in a lateral decute position in residency, and then I did my fellowship with Adam Cantor, which was all lateral decute. I actually came back to WashU and started doing those prone, and it's been 3 years, and I haven't switched back. I find it a much better technique overall. And then I did the Dr. Ogunlade endoscopic fellowship when he started. I just scrubbed in with him. He helped train me along, and then kind of been on my own somewhat since then.
While we go to the next slides, I do have a question for you, Dr. Fez. How do you determine which patients you think need a direct decompression with your prone lateral versus not? What's your thought process or your workflow in deciding?
Yeah, so usually, as that MRI showed, you get really good resolution of a lot of those symptoms from a indirect decompression. The areas I find that don't do quite as well from indirect are something that's a static obstructive lesion, something like a synovial cyst or a calcified disc or calcified ligament, things that won't really change with tension over time. Those are the ones where I find that actually I'll drop a tube during that case and do a direct decompression at that time. I do counsel most of my patients that even if they have bad radic, most of the time I just do indirect decompression. And after doing hundreds of these cases, I've only had a handful where I've had to go back at 3 or 6 months later and drop a tube through an incision or an endoscope now, and relieve any kind of stenosis that did not resolve over time. And it's mostly those cases that are calcified or a lesion that just is not going to go away with stretching that area.
Awesome, thank you.
All right. Well, my name is John Cloissy. Thanks everyone for being here and for the opportunity to present. I have two quick cases of different ways of managing degenerative spondylolisthesis. Dan and John, great talks. This is my only disclosure. So for case one, this is a 51-year-old female with low back pain, neurogenic claudication, and bilateral low extremity L5 painful radiculopathy. These are her x-rays showing a grade 1 L4, L5 degenerative spondylolisthesis. Um, a few millimeters of motion on flexion and extension, however, not the most unstable spondylolisthesis. Here is her MRI showing severe canal stenosis and bilateral lateral recess stenosis and a large right-sided facet fusion and multiple facet cysts and bilateral facet arthropathy. So this woman had failed all non-operative treatments, physical therapy, epidural steroid injections, facet blocks and ablations, and a major component of her symptoms was back pain as well as her lower extremity symptoms. So we talked about her treatment options, which would have included an isolated decompression versus decompression infusion. And we elected to proceed with a decompression infusion surgery. So we elected to treat this with a L4, L5 MIST lift, as well as with a direct decompression and facet cyst removal. To Dr. Hafiz's point, we did a direct decompression with removal of that facet cyst because I was not convinced that relying on indirect decompression alone would have sufficiently addressed her symptoms. I'm a big believer in indirect decompression, and I do rely heavily on indirect decompression. However, in this case, we did perform an indirect decompression. She is now almost 1 year out from her surgery. These are her 3-month post-op x-rays. Her pre-op symptoms are gone, and she's doing well. So the next case, this is a little bit of a different case. So this is an 80-year-old woman with neurogenic claudication and left lower extremity L4 and L5 painful radiculopathy. She has a significant past medical history of including metastatic stage 4 ovarian cancer, for which she had undergone surgery, radiation, and chemo without evidence of recurrence, multiple DVTs and PEs on Xarelto, and osteopenia on reclast. Looking at her medical history, it sounds like she really does have a lot going on. However, she's one of those patients where you walk in the room and she looks quite young and younger than her chronological age. She's very physically fit, you know, um, uh, independent lady. She's very active in her community. She had failed extensive non-operative treatments and was really debilitated by her symptoms. So these are her lumbar spine x-rays, which show a grade 1 to 2 spondylolisthesis at L4-5, as well as a subtle grade 1 degenerative spondylolisthesis at L3-4. There's perhaps a few millimeters of motion on flexion and extension at L4-5. Does not appear to be instability at L3-4 on flexion extension. And here are some sagittal cuts middle, right, and left, showing severe canal stenosis at L3-4 and L4-5. And then some axial slices showing, again, severe canal stenosis and lateral recess stenosis bilaterally at L3-4 and L4-5. She does also have a chronic L3 compression fracture and would therefore fall under the category of having osteoporosis by definition. So in thinking about this 80-year-old female with medical comorbidities, neurogenic claudication, lumbar radiculopathy, I think we have multiple treatment options. So one could consider an L3 to L5 decompression fusion, or a larger operation, L2 to S1 pelvis fusion with decompressions. Or perhaps you could also do just an isolated decompression of these levels in this woman in whom back pain is not a major complaint, and her symptoms are primarily neurogenic in nature. So that's what we decided to do. We did a 2-level tubular decompression. This was I performed this using a tubular retractor, similar to the technique that Dr. Ogunlade described: unilateral laminotomy, bilateral decompression. And the patient has done very well. Her symptoms were gone the same day of surgery. She took a little bit more time in the hospital, but ended up being discharged on postoperative day 2. And now is over a year out from her surgery. These are her pre-op x-rays, and then these are her 3-month post-op x-rays, which don't show any significant progression in her spondylolisthesis. She's very happy. She's now on Forteo, so that if she were to develop any additional symptoms, potentially a fusion may be an option in the future. However, with her comorbidities and age and how happy she is right now, hopefully will not need any more surgery. So that is just another example. We're prepared to go bigger in the future if needed, but hopefully not. And this is just an example of not burning any bridges. That's one thing that I tell patients in whom we're, both fusion and a decompression may be an option. We can always do a small decompression surgery, and if things progress or if they develop any issues, we can always come back and do a fusion in the future. So just two quick cases, and thanks again for the opportunity.
Dr. Closely, just well, Mark's loading that. When you counsel your patients during those decompressions in the setting of that spondy, what kind of things are you telling them, and you know, how you're making your decision, why you're choosing to do that versus going straight to a fusion?
Yeah, so I, first try to figure out exactly what the patient's complaints are, and if back pain is a significant complaint, in addition to lower extremity symptoms, then I would either counsel the patient and say that if we're thinking about a decompression, the goal of a decompression surgery is primarily to address lower extremity symptoms. It may be helpful in addressing back pain. However, the decompression may be most effective at addressing lower extremity symptoms. And then also just getting a sense for what the patient's comorbidities are, what their risk profile may be for a larger surgery versus an isolated decompression. Those are all things that kind of factor into that decision-making process.
All right, Mark Lambrechts. My talk's going to be mostly case presentations and going over factors I consider when selecting the surgical approach for degenerative spondylolisthesis. Disclosures, I'm involved in some journals and a consultant for Kuros. Okay, so these are kind of some of the things that I think about when I'm looking at a patient that has failed conservative treatment, is ready for surgery. The main thing that I look at is what's the surgical level that you're working at. If it's 5'1", maybe a really good candidate for an A-lift potentially. Other levels, kind of everything else kind of gets brought into the picture for me. Is the slip dynamic? What's the severity of the stenosis and disc collapse? Where is the stenosis? Is it ventral, dorsal, mostly foraminal? Bone quality and other medical factors, and then how many levels do you need to treat? And then patient preference obviously comes into play here as well. So this is case number one. There's kind of limited information you have to go off of, but 83-year-old female presents to clinic. She essentially has cauda equina, no longer has bowel bladder control, out of perineal numbness, terrible left leg radiating pain. And this has all kind of been developing over the last week. You can see that she clearly has a left hip fracture, so you know that her bone quality is not going to be great. But she's got 4'5", 5'1" slips, as well as pretty terrible central canal stenosis at 4'5". Pretty big slip at 5'1", still severe central canal stenosis, but not nearly as bad as the 4'5" level. So this is kind of, again, the flow chart that I use to go through everything. You know that it's a 4'5", 5'1". It's not really a dynamic slip. I have flexion radiographs. It's really severe stenosis, both ventral and dorsal compression, severe osteoporosis, and then her son was a physician as well, and he left the how we treated it up to me. So there's a couple different options here. I gave you the PROMIS scores as kind of a prelude to how she did. So you can see that her pain interference was extremely high at 70, physical function pretty low at 30. She was in a wheelchair when she first saw me. So I will open it up to everyone else and on what your thoughts are and what you would do.
Yeah, maybe our other speakers can kind of just give their thoughts and what their inclination would be on this case.
Yeah, if she was having more leg pain than back pain, I would probably do a 2-level endoscopic decompression. If she was having back pain at all, I'd probably do a 5'1", probably just T-lift and decompress 4'5". Overall, that looks like it's the worst level. Since she's 83. Ideally, I do an A-lift at that level, but at 83, I'd probably not put her through that.
Yeah, I completely agree. I think me being a little more aggressive endoscopically, I would probably try to treat this initially endoscopically, 2 levels, especially if there was not a significant amount of back pain. But if she had any degree of back pain, I definitely would need to do a fusion. And then the question is whether or not there's enough. Do we need to do a foraminal decompression? Do we need to do an indirect decompression as well? And her bone quality would kind of tie into whether or not I decide to do an indirect decompression, but some form of fusion probably would be in her future, given her overall degree of slip and her pain, depending on her back pain, I should say.
Yeah, I'd say, back pain, it's probably 30% of it, 70% leg pain, but the concern for me is cauda equina. Am I going to be able to do enough and make sure that it's completely decompressed endoscopically?
And we're gonna have John weigh in too, but for those doing fusion here, osteoporosis in this 85 or 83-year-old, how much are you doing anything different? Are you considering that or using cement or anything?
Yeah, for this, I mean, if it's got Aquina, then I would probably just do a decompression only. Um, give her some room. But if it's if you have time, then yeah, I'd get her treated for a while, do cement augmentation of the screws if possible to support it. But again, the severity and the duration of the symptoms and how much time I have to augment her matters a lot.
John, you want to weigh in too, or you want me to go to what he did?
Yeah, sorry, I had an issue. I didn't see the images for some reason
Oh,
for a little while, but it sounds like if a major complaint of hers is back pain, I would be more likely to include a fusion in my treatment for her. And also
okay. Oh,
with the severity of that stenosis at 4.5, I think you're in order to achieve an excellent decompression, I think I'd be more likely to incorporate a fusion.
yeah, so that's what I ended up doing. She had pretty terrible bone quality. Anytime there's a decent amount of decompression from the front and back, it makes me a little bit less inclined to do a decompression only. And then with cauda equina, I will still do like cauda equina pretty much all open just to make sure that I've completely decompressed anything. I don't want to leave anything up to chance. So that's the one thing that 100% of the time I'm still doing open. Um, her bone quality was absolutely terrible. So I tried to get a little, probably was overly aggressive with getting a reduction. Probably didn't need to do that. Tried to get some reduction at 5.1, and one of the screws failed. So I put two pelvic screws on that side and one on the other side. I think this is 3 months out, and she's back in New York now. So I didn't see her at the most. I think she's actually 6 months. These were the 3 months X-rays. Um, so far holding up, but we'll see long term about if she fuses. Obviously, bone quality is not very good.
I think anchoring that to the pelvis in that setting is a good idea, regardless if that screw failed or not.
You also did a nice job of keeping her lordosis there. I think all of us see a lot of these where somebody does something and they end up very flat, and then you're off to the races doing the level above, and even despite her bone quality, looks like at 4 or 5 you're able to maintain good lordosis here. She'll probably be able to stand up and maybe minimize risk of future surgery.
Yeah, she's back to walking through grocery stores, so little bit of. I'm really the goal is to make sure that you're not kyphosing. I think we might have added 5-10 degrees, nothing crazy. Um, all right, so that's the last patient was my typical patient. This is very atypical for me. A little more, I think these patients see either Ogunlade or Hafez. 46-year-old female, basically all back pain. She can't walk more than a couple blocks at this point. It's been going on for a year. She's tried all these conservative treatments. If you look way on the far right, you can see that she's got extreme mobility on flexion films. Um, but when she gets to the MRI, you can see that almost everything completely reduces. And she essentially has no stenosis at all. Let's see if so again, surgical levels 4 or 5. Really the key thing here is the slip is dynamic. Oh, that gives it away. I guess you can go ahead and what are your thoughts? I mean, I think your main treatment options here are probably going to be either a prone lateral or a TLIF.
You know,
But
I have one of these that was just back pain like this, and I actually did a medial branch nerve transection via endoscope that Dr. Ogunlade taught me, and it actually worked really well. Just treats the back pain itself without actually having any nerve-related issue. I would have done a prone lateral for this probably, but that's one non-surgical option or non-fusion option. The other one might be, I've never done one, but a TOPS procedure as a good motion preserving non-fusion option.
yeah, I think those are reasonable options. I don't know how long medial branch nerve transection is going to work when it's possible, but I mean her the amount that she goes into flexion, things I think are going to get worse pretty quickly in terms of her instability. But I think TOPS is a reasonable surgery. I don't think anybody's at WashU is doing them right now, but all right. Well, let's go ahead here. I already gave it away anyways. Did an MIS TLIF for her. You can see her promise scores. She did quite well following this, back to walking, basically back to normal activities at this point. And is very happy.
So John, are you
I think
doing
so.
a medial branch block for this patient, or are you going to fusion?
Yeah, my first option, again, being aggressively an endoscopic surgeon, really aggressive. Like I tried things that you probably shouldn't do endoscopically first. You should just go to fusion. But typically patients are not always excited about a fusion option. So I would try the endoscopic approach. And if it fails, like I said, no bridges burnt, like Dr. Closey mentioned, so if it fails, we tried it. And then eventually you might need a fusion, but they're more willing to proceed with the fusion after trying the endoscopic procedure. But I have done the MBTs in patients with mobile spondies and fixed spondies and only back pain. They actually do really quite well. How long they last, that's a good question. I think they develop different types of mechanical back pain and then need a fusion from that point on. But, surgery goes in hand with lifestyle changes. So I counsel a lot of patients about the importance of maintaining a strong core, paying attention to their posture. And some of them listen and they get better. Some of them don't need a fusion. But I think I'm a MIS TLIF guy right now. I'm trying to learn the prone lateral from Dr. Hafez. So when I get that in my armament, I'll probably do prone lateral as well.
To Dr. O's point, I think if it's just facet mediated pain and they get some relief with the facet block, then MBT is a great option. Over time, that's probably going to become more discogenic mediated pain. And then at some point, you're going to have to probably do something in the anterior column.
Yeah, I mean, she'd had medial branch blocks and stuff like that as well that weren't effective. So I do think that's a reasonable option to try and prolong it. But a lot of times I found these highly mobile ones don't get much relief with the medial branch blocks. All right, so kind of back to the unhealthier patients, 74-year-old female, almost all right-sided radicular symptoms to the point that she's not really ambulating, going to the exam room. She's laying on the exam room table, and that's usually my litmus test for this person's in severe radicular pain, if they're not even willing to sit up. Really not too much mobility. This is just the X-ray on the left is just an upright film. X-ray on the right is a flexion film, so not a true. I didn't put in the extension one, but you can see it's not truly, I don't think, a mobile slip. Here are the MRIs. So you can see there's a combination of some disc herniated out at the L4-5 segment, as well as some ligament and flavum infolding. I'd say the disc herniation is slightly worse than the ligament and flavum infolding. If you look at the facets, I'm a big believer in looking at the facets, kind of seeing how much arthrosis there is, seeing how much effusion there is. You can see there's not much effusion. There's a lot of facet arthrosis. So usually these aren't very mobile. So it goes back to this. It's at L4-5, not really very dynamic. Stenosis is pretty much everywhere, including in the foramen, especially on the right side. Pretty poor bone quality. Only one level of spondy, but severe stenosis. So then you get to patient preference, and this person 100% said, "You will not fuse me." So then you're pretty much stuck at decompression here. This is the PROMIS scores. So actually not too bad for somebody that I told probably needed a fusion. Thoughts? How are you going to do the decompression? Or are you going to tell her decompression is not an option, you need a fusion?
I mean, I've tried decompression on patients like this endoscopically, and almost always these patients need indirect decompression as well, specifically because the degree of that facet subluxation, even if you go ahead and decompress it, when you see that synovial cyst within that facet joint, that means that you're going to decompress it, they're going to get some relief, and then it's going to slip forward even more. You can actually see there's an entrapped nerve on that right side, on that upper right-hand corner. So I agree with the decompression because that's what the patient wants, but eventually she's going to need a fusion. The question is, how long is she going to wait before she does it? But I still think a decompression first is a great way to go. And again, being biased towards endoscopic, I would have done this endoscopically.
You go in interlaminar or transforaminal?
Interlaminar. I would have used the big endoscope, the 10mm scope, use an aggressive shaver burr and really undercut the lamina on both sides, and then go out the foramen and undercut the joint.
Would you go after that disc at all and try and buzz it and shrink it backwards, or just leave it as is?
Leave it as is. The problem is the moment you start taking out that disc, they're going to have a reherniation.
Not take it out, but just buzz it down with the RF probe. And
Yeah, buzz it down is reasonable.
Yeah.
I've made the mistake of doing the in the same kind of case, grade 1 slip, going after the disc because I thought it was going to be a problem for not enough room creating enough decompression. And that patient did fine for about 2 weeks. Then they had further collapse of disc space, and they reherniated the disc material out of the defect that I created. So you see a slip, you see, a stenosis. If you can buzz it, but don't take out the disc because you're just going to make it worse. And so you end up having a fusion.
I'd probably do this endoscopically over tubular. The data on tubulars and fixed spondies is pretty good. Most of the ones I've done have been all right, but I have had a couple where, in this case, I've caused worsening, diastasis of the facet joint. So if I did this, I'd probably do a left-sided approach, tubular or endoscopic, and do over the top and cut out that right, ventral facet joint there to kind of go out the foramen there, versus starting ipsilaterally on the right side, just because I'm better at staying out of the joint and don't get too lateral and cause more damage.
Hey, Dan, and the ones that you've done where you said you caused some diastasis of the joint there if you stayed ipsilateral, I'm looking at those facets being pretty vertical. In those patients, have you had to go back and revise them or not?
Yeah, I had to go back and fuse it because they ended up having motion.
Yeah.
I took them from adynamic to dynamic, probably by just taking too much bone on that medial aspect, or maybe even cutting into the synovial cyst there and pulling that out. But so now I'll usually approach these from over the top because I can stay out of it, and you can kind of work your way, like I said before, inside out and kind of keep the outer facet capsule intact more.
Yeah, and I agree with that. To Dan's point, if you look at that, again, that trapped nerve is if you go left to right, start on the left side, go contralateral, it's much easier to get to that trapped nerve and decompress it thoroughly going over the top than if you were doing ipsilateral. So my rule of thumb is if you're doing an endoscopic decompression and you need to do a foraminotomy, come from the contralateral side that you need to do the foraminotomy on.
The only part that hurts you is if you do want to go after that disc. Now you have to go over the top and then sweep the thecal sac back medially. It's doable, especially if you rotate the table. It gives you a little bit better angle, but it's a little bit more challenging. And depending on how old they are, how thin their dura is, you could definitely cause a little bit of dural puncture there if you pull too hard or poke. So if you're going to go after the disc, then you're kind of in this more difficult situation of maybe going ipsilateral.
Yeah, kind of to your point, and I hate to keep belaboring the point. I did that case, went over the top, got to the disc the same way you described it. The patient did good for 2 weeks, and then the disc herniated outside the axilla and was actually sitting dorsally. So I was surprised by that. Never saw it before, which is why I don't do these disc anymore. Sorry, go ahead, Mark.
Well, I took a different approach and I actually did it transframily, mostly went after the disc and removed some of the SAP and took some ligament. And she had still has back pain, but had complete resolution of her radicular pain. Um, the disc actually was, when you see those old discs that was all crumbly, it was just all crumbly stuff. So I didn't actually need to go into the disc space and it was all just extruded, kind of crumbly old disc. So she has not had, I think she's about 3 months out and has had no um, recurrence of her symptoms.
Nice.
So that talks about it. So you can see no interlaminar decompression there compared to the pre-op. All right, last case. I think we're probably running out of time here. I don't know how much time we have left. This is a very typical one of my patients, 85-year-old female. She's no longer ambulatory over the last 3 months. A ton of back pain, leg pain's basically as bad as the back pain. She's wheelchair bound due to the severity of both. You can see MRI 4-5, very severe stenosis, probably the worst one we've had so far in all these cases. Facets look very similar to the last patient. Terrible, terrible osteoporosis. She's got ghost bone. Um, and I gave the promise scores. So she did better. Thoughts?
She has no canal whatsoever. You don't have any CT or bone. It's kind of hard to see the facets there, but um, if she's osteoporotic and I would probably go after the leg pain first, see how she does. If that's what's keeping her from being ambulatory, do a decompression, try and get her on some form of anabolic or something to make her bone stronger. If that slip gets worse, then fuse that. But yeah, at 85 with that, I would either say non-op or decompression only.
Yeah,
Yeah,
I agree with that.
same. Yeah, that's a challenging case for multiple reasons. I mean, she's got significant psoas atrophy on that image. She's got significant multifidus atrophy, and I mean, she definitely needs a fusion, but she's a terrible candidate. So I would try again decompression only, and then see how she does. Get her on those medications, and hopefully bring her back for a fusion if it gets worse. So Mark, thanks for taking all these very osteoporotic and old patients. We appreciate it.
And is there
Uh,
Mark, is there a time that she's non-ambulatory for that you say, look, it's not worth doing anything at this point?
no, I mean, she was just so miserable. I said, look, you're not a candidate for a fusion. You've got a compression fracture. Uh, Things will absolutely get worse. And but you can see her pain interference is a 70, so I have a hard time saying no, you can't have surgery, we can't do anything when it's that bad. So let's see here. Yeah, here you can see the pre-op versus post-op to John's point. You can see if you take a look at 4-5, you can see we did um an interlaminar ULBD. And remove the ligament. And she's actually, shockingly, her back pain is now, she says 2 to 3 out of 10, and she has absolutely no leg pain. So all was just the decompression. And she's, I think, 6 months out now.
Nice save.
Right.
And
What are you guys' thoughts closely? What do you think about doing these, laminectomies, even MIS, and these osteoporotic patients? We don't, maybe not do laminoplasties in patients with, bad bone quality because of that. How come we feel so comfortable doing lumbar decompressions and osteoporotics?
Yeah, I mean, I feel like the advantage of these unilateral laminotomy bilateral decompressions, whether you're performing them endoscopically or through a tube, is that you're preserving the midline structures. Dr. Goodwin's point earlier, you're really preserving as much of the soft tissues, stabilizing structures as possible. And I think in these patients who are absolutely miserable, it's worth a try in a lot of cases. And it seems to be, um, you're by preserving those stabilizing structures, we're really hopefully putting people at minimal risk for slip progression and those types of issues, and hopefully being able to buy them some relief in their symptoms.
Yeah, I mean, you can see it just on these images, like there's no violation of the facet. I mean, she doesn't have any muscle to begin with, but you're not you're not injuring the muscle. So really the only thing that's providing any stability that you're taking away is the ligament, which we know is probably not doing that much stabilization because your body keeps building it up due to the instability that's there. So there's just a lot of preservation of the stability with this.
She make it out of the wheelchair?
Yeah, she's walking to clinic.
Uh-huh.
She's still, her legs are quite weak. She just doesn't have any endurance. She's in PT now. But at Barnes, you know how far that walk is. It's at least a quarter of a mile, and she made it all the way to clinic walking.
That's the
Great.
test.
A great outcome.
Yeah, great save.
I'm glad you're taking all these for us as
Yeah, I feel like I'm getting referred all of them by everyone else. This is like the only person I see in clinic.
purely accidental.
Oh, all I'm seeing is that you're the master of handling these patients.
Yeah.
No. Actually, John's the master endoscopist. He's the one who should be seeing her.
Well, it's interesting because I did a case this past Wednesday. It was a 93-year-old, no, sorry, 97-year-old, 2-level endoscopic laminectomy awake, and that guy was just, again, same presentation, same picture. And I think to your point, the power of endoscopy, once you mount the learning curve, is you can take care of some really sick people that unfortunately are not a candidate for anything else. So I'm really happy that you guys are all adopting it and that we've built quite a program. And Matt, thank you for taking the time to get us involved and also taking care of some of these more complex deformities and tumors so we can do the MIS stuff, because I definitely love my practice. I don't know about everybody else, but I love my practice.
Well, certainly thank you guys. I'm learning all the time from you guys, and I have a feeling this is going to be a very highly viewed session with the four of you all in here going through these cases. So there's lots to pick up from each one of these cases. So thank you all again for making the time to do this.
Thanks for having us.
Thank you.
All right, with that, I think we can wrap it up and see you guys next week. Thanks again, guys.
Thanks, guys.
Yeah, thanks, Matt.